The next topic is plasma cell disorders. The hallmark of plasma cell disorders is production of immunoglobulins. It can either be complete immunoglobulins or it can just be a fragment. So these are formed from the abnormal plasma cells. All these plasma cells that are forming the immunoglobulin are monoclonal, and all the immunoglobulin can be detected in both serum and urine. This protein is called as M protein, and M stands for monoclonal. It is not to be confused as IgM. It is not IgM, it is M for monoclonal. So the amount of M protein or concentrations of it in the serum and urine in a patient denotes the tumor load in the patient. In few cases, only the light chain of immunoglobulin is seen within the urine, and this particular protein is called Bence-Jones protein. There are a few conditions where M component can be seen apart from plasma cell disorders. So these form a differential when M band is detected. These include cirrhosis, sarcoidosis, parasitic infestations, autoimmune diseases, lymphoid tumors, and non-lymphoid cancers as well. Now, amongst the plasma cell disorders, the first and foremost and the most important is multiple myeloma. This is a disorder consisting of clonal proliferation of plasma cells within the bone marrow. It is not present in lymph nodes. The symptoms in multiple myeloma are due to tumor expansion, the local and remote actions of products secreted by the tumor or the plasma cells. About 70% of the patients have bone pain in the form of back pain or ribs that are painful. This classically increases on movement. These bone lesions occur due to osteolytic response, and they are usually multiple lytic lesions, and because of this, radiographs form an important part of diagnosis. The tumor cells produce the osteoclast activating cytokines. This leads to calcium mobilization, which can lead to increase in the serum calcium levels, precipitate the symptoms of hypercalcemia in these patients. There is a decreased synthesis and increased catabolism of immunoglobulins, both normal and abnormal. This leads to hypogammaglobulinemia. A third pathophysiologic mechanism is poorly defined tumor leads to reduced granulocyte migration. These two mechanisms increase the risk of infections, and the most common infections seen are pneumococcus, Klebsiella pneumoniae, Staph aureus. These are seen as lung infections, Escherichia coli, and other gram-negative bacteria are seen in urinary tract infections. Almost 75% of the patients are affected by hypogammaglobulinemia, leading to repeated infections. About 25% of the patients experience renal failure. This can be due to several factors. The first one among them is hypercalcemia, infections, toxic effects of light chains of immunoglobulin, urate nephropathy, and dehydration. There can be neurologic symptoms which results due to hyperviscosity, circulating cryoglobulins, and rarely amyloid deposition within the nerves. About 80% of the patients develop anemia. This happens due to myelophthisis and inhibition of erythropoiesis by tumor cell products. Patients can also have clotting abnormalities leading to bleeding. Let's now look at the diagnosis of multiple myeloma. A marrow plasmacytosis composing of more than 10% lytic bone lesions seen on radiography, and serum or urine M component together form the classic triad. There is another plasma cell disorder called monoclonal gammopathy of uncertain significance, or MGUS in short. This is a more common compared to multiple myeloma, and it is seen in approximately 6% of the population which is above 70 years. These patients classically have a serum M component of less than 20 grams per deciliter, a low serum beta 2 microglobulin levels, plasmacytosis in marrow will be less than 10%, and there will be no bone lesions or lytic lesions on X-ray. These patients generally have a lifetime risk of progression into multiple myeloma. The multiple myeloma progression in lifetime will be approximately 25%. There are a few risk factors for these patients which increase the risk of development of multiple myeloma, and these include increased paraprotein levels to more than 15 grams per deciliter. Paraproteins that are formed by IgM, or a free light chain of less than 0.26 or more than 1.65. There are two important staging systems to prognosticate multiple myeloma. The first one is Dury-Salmon staging, and the second one is international staging system. Let's now look at the Dury-Salmon staging. It is divided into stage 1, stage 2, and stage 3. Stage 1 is when the patient has a hemoglobin of more than 10 gram percent, a serum calcium of less than 12 milligrams per deciliter, a normal bone X-ray without any lytic lesions, an M component level that is low. This is further subdivided into 3, that is IgA, IgG, and urine light chain. IgA of less than 3 grams per deciliter, IgG of less than 5 grams per deciliter, or urine light chain of less than 4 grams per 24 hours is considered in stage 1. Stage 3 is when hemoglobin of the patient is less than 8.5 gram percent, serum calcium is more than 12 milligrams per deciliter. There are lytic lesions seen on radiography, and patient has a increased M component that is again divided into 3, IgA of more than 5 grams per deciliter, IgG of more than 7 grams per deciliter, or urine free light chain of more than 12 grams per 24 hours or per day. Anything that is not stage 1 or stage 3 is considered as stage 2. Dury Salmon staging is further subdivided based on serum creatinine levels into stage A and stage B. Stage A is when serum creatinine is less than 2 milligrams per deciliter. Stage B is when it is more than 2 milligrams per deciliter, indicating renal dysfunction. Now, to look at the prognosis, this staging is utilized. So let's look at the stage and median survival. A patient in stage 1A has a median survival of 61 months. Stage 2A or B has a median survival of 55 months. Stage 3A has a median survival of 30 months. And stage 3B has a median survival of just 15 months. The other staging system is international staging system. It is divided into stage 1, stage 2 and stage 3. They are based on the serum beta 2 microglobulin level and serum albumin level. Stage 1 is when the patient's beta 2 microglobulin level is less than 3.5 milligrams per liter and albumin is more than 3.5 grams per deciliter. Stage 2 beta 2 microglobulin less than 3.5 milligram per deciliter with an albumin of less than 3.5 grams per deciliter, or the beta 2 microglobulin of in the range of 3.5 to 5.5 milligrams per liter. Stage 3 is considered when the beta 2 microglobulin level is more than 5.5 milligrams per liter. Let's look at the median survival in each of these stages. In stage 1, the median survival is 62 months. Stage 2, the median survival is 44 months. And stage 3 is when the median survival reduces to 29 months. Let's look at the treatment for multiple myeloma. About 10% of the patients have a slow progression. This is called smoldering myeloma. They generally do not require medications until paraproteins rise above 50 gram per liter or have a progressive bone disease. In cases with solitary plasmacytoma and extramedullary cases, localized radiation usually cures the disease. Supportive care includes medication for hypercalcemia, early detection and treatment of infections. The skeletal lytic lesions are counteracted by chronic bisphosphonate therapy. Patient should be hydrated properly, and this prevents urate nephropathy also. The therapy aimed at tumor is usually palliative. Initial therapy is based on whether the patient is eligible for high dose therapy and autologous stem cell transplantation. In transplant eligible patients, it's better to avoid alkylating agents. The preferred choice of medications include lenalidomide, which is given in the dosing of 5 to 25 milligrams per day orally for 21 days every 28 days. This is given along with dexamethasone in the dosing of 40 milligrams on day 1 through 4 each month. Other medication given is bortezomib, which is given in the dosing of 1.3 milligrams per meter square of body surface area, either as IV or subcutaneous route on day 1, 8, 15. This usually gives a 100% response, with around 1/3 patients showing complete response. Once this is achieved, maintenance is given by lenalidomide therapy. Patients on lenalidomide also require thromboprophylaxis. Patients who are transplant ineligible can also receive the same medications. Plus, here patients can also receive alkylating agents, and the therapy is mostly palliative. Main agents include melphalan, given in the dose of 8 milligrams per meter square orally for 4 to 7 days, which is repeated every 4 to 6 weeks. This is given along with prednisone, and this usually gives a response in about 60% of the patients, where they see a symptomatic improvement, and about 75% of the patients also see a decline in M component. Adding bortezomib is shown to improve response to melphalan. There are new medications which are being studied. These include proteasome inhibitor such as carfilzomib and ixazomib, immune modulators such as pomalidomide, monoclonal antibodies daratumumab, which is anti-CD38, and elotuzumab, which is anti-SLAMF7, histone deacetylase inhibitors, panobinostat. All of these are in stage of clinical trials. So now the next topic is Hodgkin's lymphoma. Hodgkin's disease or Hodgkin's lymphoma is a tumor of Reed-Sternberg cells. So these are aneuploid cells which usually express CD30 and CD15, but they may also express other B or T cell markers. Most of the cells are derived from B cells, where immunoglobulin genes are rearranged but not expressed. Etiology is unknown, but there is a 99-fold increase in twins, especially identical twins. There are 4 distinct histologic subtypes: nodular sclerosis, mixed cellularity, lymphocyte predominant, and lymphocyte depleted. Nodular sclerosis is the most common Hodgkin's disease, amounting to 75% of the cases. Mixed cellularity contributes to 20% of the cases of Hodgkin's. The remaining 2 share around 5% of the cases. Let's look at the clinical features. Presents as an asymptomatic lymph node enlargement or adenopathy associated with fever, night sweats, weight loss, and pruritus. In nodular sclerosis, mediastinal lymphadenopathy is common and it may produce cough, superior vena cava obstruction, or even spinal cord compression. As a general rule, liver and bone marrow are rarely involved. These symptoms of fever, night sweats, weight loss, and pruritus are B symptoms. And there are various differentials for Hodgkin's disease: infections, mononucleosis, tuberculosis, viral diseases or viral syndromes, toxoplasma, histoplasma, non-infectious diseases such as sarcoidosis is a differential with mediastinal nodes and hilar nodes. Other malignancies can also present with the B symptoms and lymph node involvement, especially the head and neck cancers. The Ann Arbor staging system has stage 1, stage 2, stage 3, stage 4, stage A, stage B, and stage E. Stage 1 is involvement of single lymph node or single lymph node region. Examples include spleen, thymus, Waldeyer's ring. Stage 2 is involvement of two or more lymph node region but along the same side of diaphragm. Stage 3 is when two or more lymph node region is involved but they are on different sides of diaphragm. They are further divided into stage 3-1 and stage 3-2. Stage 3-1 is when subdiaphragmatic involvement is limited to spleen, splenic hilar nodes, celiac nodes, or portal nodes. Stage 3-2 is when subdiaphragmatic involvement also includes para-aortic, iliac, or mesenteric nodes, along with lymph nodes involved in stage 3-1. Stage E is localized solitary involvement of extra lymphatic tissue excluding the liver and bone marrow. Stage 4 is involvement of extranodal sites that are beyond, that are designated in the stage E. Stage A is no symptoms. Stage B is unexplained weight loss of more than 10% of the body weight in the last 6 months before the investigation, or unexplained persistent fevers that measure more than 100.5 degree Fahrenheit in the previous month. Let's now look at the treatment for Hodgkin's lymphoma. About 85% of the patients are curable. The choice of therapy is usually either chemotherapy or combined modality. Patients in stage 2 usually receive a medication regimen called ABVD regimen, given in 2 or 4 cycles. ABVD is A for adriamycin, also known as doxorubicin, B is bleomycin, V is vinblastine, and D is dacarbazine. Patients who are in third or fourth stage of the disease usually receive 6 cycles of ABVD regimen. Other options include replacing bleomycin with an anti-CD30 immunotoxin called brentuximab, a large mediastinal mass, which is considered as more than 1/3 the size of the chest diameter. If a large mediastinal mass is present in any stage of Hodgkin's disease, patient should receive a combined modality therapy with meclorethamine, vincristine, procarbazine, and prednisone, called MOP therapy, along with ABVD regimen, and patient should subsequently receive mantle field radiation. About 1/2 of the patients do not respond to initial therapy. Such patients require to undergo a high dose therapy plus autologous stem cell transplantation. In long-term follow-up, it is found that patients are dying due to radiation toxicity and due to diseases like myocardial infarction, stroke, and second cancers. And hence, to prevent these, a combination therapy should be utilized. A combination therapy should be utilized. Okay, so that brings us to the end of hematology rapid revision. In this 6-part series, I hope I've cleared all the topics. So read well and all the best for your exams. Thank you.